Hello and welcome to the fifth and last webinar in this series that FHR 360 has the pleasure of hosting in partnership with Africa CDC, a series where global experts hold a conversation around critical aspects of COVID-19 response. Drawing from their vast experience, they share with us global best practices and isolate those adaptations needed to optimize outcomes in resource-constrained settings. Early in the pandemics, many people warned of COVID-19's potential to subvert resources away from TB and other disease control programs. Well, today we will explore strategies proving successful in keeping TB program activities going, even as countries respond to the COVID-19 crisis. Please share your questions on this topic through the chat feature. I will collect them and the panel will answer at the end of the webinar. My name is Dr. Otto Chabikuli, Director of the Global Health Population and Nutrition Business Unit at FHR 360, and I'm here with three prize guests, well-known names in the global TB community. Dr. Lisa Stevens, joining us from Bangkok. Lisa is a Senior Technical Advisor for Tuberculosis and HIV with FHR 360 in the Asia Pacific Regional Office in Bangkok, Thailand. Lisa is a clinician with expertise in disease prevention and care in resource-constrained settings. Program design with a focus on tuberculosis, HIV, and emerging infectious diseases, including COVID-19. Her expertise lies in the prevention, diagnosis, and treatment of TB, especially multi-drug resistant TB, including the introduction and scale-up of new drugs and regimens. Currently, Lisa supports FHR 360 TB programs in Bangladesh, Cambodia, China, Indonesia, Myanmar, and the Philippines. Good evening, Lisa. Thanks for making time to be with us.
Thank you, Otto. I'm very excited to join this webinar. Thanks.
And we have also Dr. Norbert Ndjeka joining us from Pretoria, South Africa. He's a specialist in family medicine and serves as the Director, Drug-Resistant TB, TB and HIV, Department of Health in South Africa. He's the chair of the Regional Green Light Committee for WHO Afro and a member of the Global Fund Technical Review Panel. Good afternoon, Norbert.
Good afternoon, Otto. I know it is morning on your side. It is afternoon here.
It's so true.
Yeah.
Finally, we have Professor Madhukar Pai joining us from Montreal in Canada. Madhu is a Canada Research Chair in Epidemiology and Global Health at McGill University and the Director of McGill International TB Center. He serves as the Chair of the Public-Private Mix Working Group of the Stop TB Partnership. Madhu's research is mainly focused on improving the diagnosis and treatment of tuberculosis, especially in high-burden countries like India and South Africa. He serves on many editorial boards, including Lancet Infectious Diseases and Public Library of Science Medicine. Good morning, Madhu.
Hi, everyone.
Let's start the conversation with you, Madhu. The past 5 years, we witnessed great momentum in the global health community support for the fight against tuberculosis in the form of a commitment to end TB, the leading infectious disease killer. A commitment that did set ambitious targets to reduce TB death by 95%, to cut new cases by 90% between 2015 and 2035, and to ensure that no family is burdened with catastrophic expenses due to TB. And I think the past 5 years, we've seen great progress and momentum in all fronts, from diagnostic to therapeutics, including new regimens, shorter regimen, particularly for multi-drug resistant tuberculosis. Now, as alluded earlier, the COVID-19 pandemic response threatens to subvert resources from TB. We are now 7 months into this pandemic. What do we know of the impact of COVID-19 on global public health and TB in particular?
Thank you, Otto. If I can have those introductory slides up. So as you rightly pointed out, Otto, the impact of COVID on TB is quite devastating, actually. I'd like to think that if we were, climbing a mountain to end TB, that mountain has become Mount Everest, literally. And what's sad is it's not just TB. As we well know, the impact of COVID is so extensive that this infographic that we put together is one of the most depressing things I've ever written in my life, because it's not just TB, right? HIV, devastating impact, malaria, maternal and child health, immunization has come to a grinding halt in many places, non-communicable diseases, unintended pregnancies, poverty, deepest recession since World War II. So TB is most certainly a big casualty, but not the only one, which makes us wonder what the response should be, because we tend to think only TB, but the ripple effects are phenomenal, like poverty. I mean, if so many million people are going to be pushed into poverty, surely this will hit TB one way or the other. Next slide. So in terms of TB specifically, what we are seeing, and this is immediately visible, is a dramatic drop in case notifications. That is up to 50 to 80% depending on countries. And this is because multiple lockdowns and anxiety about going to a facility in the midst of this pandemic so that people might end up catching COVID has basically prevented thousands of people, millions of people from not seeking care. Deferred care seeking and reduction in services has easily accounted for many of this stuff. Many hospital wards, MDR wards, have been converted into COVID wards. Healthcare workers are now fully COVIDized, especially in the public sector, because they're called upon to scale up COVID testing, to do COVID contact tracing. So there's a massive diversion of the healthcare workforce to deal with the COVID pandemic. That means the TB workforce has shrunk. Now, diagnostic laboratories are very busy running COVID tests now. They don't have much bandwidth or energy to run TB tests. Now, people who were already on TB treatment at the start of all these big lockdowns, somewhere around March, for example, they may have continued TB treatment for a while longer until they have medicines, but surely by now they've all run out of medicines. Nobody has several months of drug supply. They only have it for 1 month or 2 months. So there is a big concern that many of them are now no longer adherent, or they've had treatment interruptions. And then, of course, I will talk to you a little bit more about the anxiety about stockouts of critical products in a second. Next slide. So here is one looming threat in the future. I think the immediate impact on reducing notifications and reducing treatment completion rates is visible. But here is my anxiety. We already know that companies like Cepheid, for example, are justifiably very, very busy scaling up their SARS-CoV cartridge production, because that's the big need of the hour. US needs it. Whole world needs it, and they simply don't have the capacity to produce and keep up with the demand. So it wouldn't shock me if that came at the cost of TB testing or other production. It may not be visible to us today, because many NTPs do have cartridges for this year because they are already purchased it, or they have not used enough cartridges during the lockdown. But by next year, I'm anxious to make sure we don't have a stock out of GeneXpert. Same thing with anti-TB medicines. We know anti-TB medicines, including bedaquiline, are mostly manufactured out of India. And India is in a desperate state right now with COVID. India was already in lockdown for almost 3 months, and India is almost surely going back into lockdowns in the coming months. And supplies from China with the raw material is also impacted. So if we don't plan for this, we may end up with a serious TB drug shortage again in the coming year, may not be visible in this year. And then obviously all TB R&D and drug trials are delayed everywhere. We simply can't even get any recruitment happening in trials. So we expect all sorts of ripple effects on TB drug policies or TB guidelines. And then the last anxiety, which I will quickly summarize and then hand over back to you, is that we are already seeing a massive threat to international development assistance. Both UK and US have sent very strong signals that that is indeed the case. And if that is the case, and if the richest countries in the world are going to pull back on their donor commitments, I can't imagine this not hitting TB funding in the coming years. We may be fine for now, but in future, what would development assistance for TB look like is a big concern. So I will stop here, and then when we talk about solutions, we can dive deeper into these issues.
Thank you very much, Madhu, for painting that picture of some of the issues that we'll be facing, or if we are not already facing them right now. Lisa and Norbert, from where you're standing in Southern Africa and Asia Pacific, does this resonate with your daily experience?
Yes, it does. For example, in our drug-resistant TB register, we've noted that the drop in terms of patients' case finding is something like 60% or 62%. We started experiencing shortage of drugs already in January. We ran out of derazidone. It wasn't a big problem because there were alternatives. But around April, May, we started to feel really, because now we're in the middle of lockdown and all the drugs that were used to replace our derazidone, we're now also starting to be depleted. So this is a very serious, I agree with Madhu. We really run a risk here, it's true, yeah.
Thank you. Lisa, from your side?
Yeah, in the countries that we're working, we've definitely seen a big drop in case notification. Across the country, somewhere between 10 and 70%. And I think the reasons that Madhu discussed are evident in all of those. In addition, we've had active case finding and contact investigation programs just completely put on hold because nobody can get to the communities. And then there's a lot of fear among healthcare workers and even people working in the laboratory. And a lot of it has to do with not being well protected. So there's personal protective equipment, the PPE shortages in too many countries, and they're not wanting to test for TB even because they don't have the proper protection for COVID as well. So those are a couple more. And as you mentioned, the clinical facilities, some of the TB hospitals have turned into the COVID hospitals, and some of the reference laboratories, TB culture labs, have now become COVID labs. We're seeing some countries do better with sort of sharing, where maybe gene expert machines are being used for COVID in the morning and TB in the afternoon, or running samples simultaneously. But it's variable. And we've got a couple countries, when you ask how their TB services are, they actually say, we're back to normal now. That's Cambodia and China. But I worry that this normal state is precarious, because as soon as there's another spike in COVID or some of these predictions that Madhu talked about, drugs running out, if that hits, the whole situation changes. Thanks.
And Otto, just to add to what Lisa and Norbert are saying, one more anxiety that I have, wearing my hat as a PPM working group chair, is that the private sector in these high burden TB countries, obviously there is this big seven that we speak about: India, Pakistan, Bangladesh, Indonesia, Philippines, Nigeria, and Myanmar. Private sector in these countries is in desperate state right now because a lockdown hit them brutally hard. Many of them simply did not open their GP facilities or their clinics. Many private hospitals had to be shut down because they had a COVID outbreak among healthcare workers. And when they are coming back online, it's a whole new normal for them, right? They have to have PPE in place. They can only see fewer clients than they saw before. And for all those reasons, the private sector is becoming more and more expensive. It was already expensive in many places. Now private sector becomes more and more expensive and less available. It has shrunk or changed its nature. And we are trying to track that through our TB PPM working group. Now, what this means is that imagine being a patient with TB symptoms in India, where 80% of people would have normally gone to the private sector, but they suddenly find this sector shrunk and difficult to access and more expensive. And they are anxious to go to the public because public is fully battling with COVID, right? And they don't want to go to a public facility and actually get COVID because they don't know what they have as TB or COVID or whatever. So you are really stuck between really difficult options right now, a very stressed, stretched, and swamped public service in many countries, and a private sector that is shrunk and more difficult to access and more expensive. So what will this mean to an average person with TB is what we don't know. How will this change the pathway of care? Will they now start going directly to pharmacies because there is no other option for them? Will they start going to informal healthcare or alternative healers? You know, we just don't know what is going on. And I think getting to the bottom of this is critical, because in PPM, even to bring it back to last year would be a miraculous achievement right now, because the whole field is getting hammered.
So colleagues, you'll understand my anxiety when I hear Dr. Tedros from WHO saying there's no going back to our normal situation, and pretty much telling us for the foreseeable future, what we're experiencing now, it is our lived reality going forward for the next several months. But you know, what COVID-19 has also done is brought to the fore an unprecedented sense of common purpose, which is making countries willing and ready to collaborate and seek and share lessons. So it is really a good time to test innovations, to look at ways of responding to this pandemic while protecting the gains of what we have invested in for the last several decades. Lisa, just turning back to you, one of the most devastating aspects of the response has been the physical distancing measures. I mean, that physical barrier limitation in mobility, not only across countries, even within countries, from your own home to where we would normally take for granted, like going for grocery or to the hospital. And that has had significant impact on access to routine services. And it is actually amplifying inequalities in places like the United States. Until we get an effective vaccine, this barrier will be a common feature in many TB high-burden countries. Now, from your experience in Asia Pacific, what are the most promising approaches that you're seeing in bridging the physical barrier to the uptake of services?
Thanks, Otto. Yeah, definitely physical distancing is having a big effect on access to health facilities. But what we've actually seen in most of our countries, besides the drop in TB diagnosis, actually the patients, at least up until now, are staying on treatment. So those that have already initiated treatment are generally continuing, and those that are being found are getting started. This is the report I'm getting in from our team. And I think a lot of that has to do with some of these new changes that are taking place. So the TB world has been talking about patient-centered care for quite a few years now, and different countries have had more success with that. But now we're suddenly really pushed into moving away from a facility-centered or system-centered system to one that's actually patient-friendly. And what some of the examples I've seen is this extension of drug dispensing intervals. So for both drug sensitive and drug resistant TB, people are now maybe not relying on the old daily dots, having to go to the facility every single day, but are getting a larger supply of drugs, which reduces the burdens on the facilities and the patients themselves. Some countries are actually having issues with drug supply when it comes. So I think that's one of the cautions. You've got to have enough available to do this extended dispensing, or what the HIV world calls multi-month dispensing. And I think Mozambique had some problems with isoniazid with TB preventative therapy and some stockouts when they started giving too many months at a time. The second is just decentralizing services and making more things available at the patient's home. So Indonesia's had a great example in some areas where drug-resistant TB medicines are actually delivered to the home. It could be a health facility worker. Some other health programs also are using some of these apps, like you can get dinner delivered to your house, you can get your drug-resistant medicines or your ARVs delivered by motorbike to your house. So I think these are things that really make it easier for the patient, and we hope continue. So there's been a lot of teleconsultation, tele-adherence monitoring and side effects, working through messaging and social media. And then a lot of trainings for our programs have all moved to the virtual modality, which means sometimes it's easier and faster to roll out some of these trainings across the country. So one real silver lining that I've seen has been an acceleration in the all oral MDR TB regimens. which it just came out, the shorter regimen recommendations just came out kind of right before the epidemic. And a country like the Philippines has now rolled out standard shorter regimen across the whole country. They started in February as COVID was hitting. They moved all the trainings to virtual, and now it's available across the country. So this is a huge advantage to patients as we're moving away from the toxicity of injectables. So I think some of these things, we're being pushed by the epidemic to accelerate, become more patient-friendly, have better regimens, and now we just have to figure out how to keep those things going and not go back to how it was before for these good and positive effects that we're seeing. Thanks.
No, that's fascinating. You remind me, Lisa, that a year ago, 2 years ago, I wouldn't go in any meeting and say, let's go away from DOTS. You will be stoned by the TB community. It was just unheard of. But the speed with which we just accept the multi-month dispensing is amazing. But Norbert, Madhu, is there something to worry about by way of patient adherence if you give them more than a day supply of medication? How do we monitor that? Because that was one of the major concerns, that patient will not be compliant with treatment regimen.
Yeah, to be honest with you, I'm personally very happy about this. One of my challenges has been that I have 3/4 of my patients, my DRTB patients, being people living with HIV. And no scientist around the world has ever given me a solution to say, how do I handle that? Because the care must be integrated, it must be comprehensive, and all that must be patient-centered. Nobody has ever given me an answer, but as a good TB person, I kept quiet for so many years. And when I see this, I'm probably one of the most excited person, because now what we tell patients can really be aligning with what we are doing, because we will see patients now who will see effort, I think. Patients are not that bad. They do well with TB. Why can't add with HIV, which is a lifelong treatment? Why would they not do well with TB? I never understood that. I think we just need to measure this and see where we go with this. I'm personally excited. DOT has probably done its job like any other good thing, So I think this is the time. For me, I remember 11 years ago when I got into my job, I started decentralization. Then we got experts at the same time. We didn't know these things would be useful. But because we decentralized so much, we managed to then even start bringing new agents, and we're the first to go all oral already from July 2018, we went full oral because we didn't know all this will come, but we just felt that it's what the patient would find more useful. So I think at this point in time, we're good. We just need to strengthen patient education. I don't know why we never use technology to monitor adherence. We've known this for years. Maybe now we're forced to use technology to monitor adherence. We do have the means to do it now. Let me end there and maybe give Madhu a chance to add. Yeah, thank you.
No, thank you. I saw Madhu was already clapping, so take it away, Madhu.
No, I just wanted to kind of give kudos to South Africa for, not only being a front runner on the gene expert scale up globally, but also the bedaquiline and the switch to all oral that was ahead of most countries. So I think it'll be critical to learn from a country like South Africa, which already had shifted to an all oral regimen, whether they can still continue that in the midst of this pandemic and the lockdowns, because that would be a great signal that it is possible to ensure continuity of care, even with all these disruptions, if you had the right systems in place. But Otto, I think both your comments on DOT was very funny. It's almost like we needed a pandemic to finally slay that beast, right? And I think we should just bury DOT. And Norbert was absolutely right. If we can trust patients to be on multi-month ARVs, there is no reason why we cannot pull that off with TB. We need to build this around trust rather than one of suspicion, which DOT is notorious for. So I think this is it. I think there is no going back to DOT after this, and any program that tries to do so will be really bucking the trend. But can we still do other things to support the patient is the right question to ask. Forget DOT. Can we give them daily reminders on their phone? Can we have a call center calling them? Can we give them a smart pill box? Can we figure out other technological approaches, or maybe more like having a peer-to-peer counseling, right? Can we connect them with another TB survivor in the neighborhood on WhatsApp so that they at least have somebody to talk to, right? Some kind of a peer buddy network to help them through the difficult phase. And that's already happening in some countries, but I think not happening in an organized way. It's happening more out of a goodwill gesture by some TB survivors who want to be good citizens or sisters, but I don't think it's quite happening in an organized way. I think we could help facilitate that kind of organized thinking around peer-to-peer support among TB survivors who are in the same neighborhood and are willing to take under their wings some other TB patients and see them through till the end.
Thank you for that. Lisa, the all-oral shorter regimen, we still have some work to do, right, in terms of harmonization and evidence gathering. Where are we? What is the status right now?
I had to get it on mute. Yeah, so the recommendations have come out from WHO for a standardized all-oral, which takes the standardized shorter regimen that's been used for the last couple of years and replaces the injectable with bedaquiline. I think there's still a need to look at resistant patterns within specific countries, and there'll be maybe better suited regimens in certain countries where resistance to specific drugs are high. So I think there's a call for operational research on other shorter regimens as well. There's still kind of a long way to go. And then we've got newer regimens that are even shorter, being used for XDR-TB, and new drugs coming and in the pipeline. So I think there's a lot more we can do, but it's been actually a really exciting year for drug-resistant TB. For me, it's getting away from those injectables and all of their side effects. But I think there is a lot of research going on in a lot of different countries, so that there'll be other options as well. Thanks.
Yeah. No, thank you. So Norbert, I know Madhu has already touted that South Africa is leading in many areas of the fight against TB. But a few days ago, the Wall Street Journal ran a title reading as follows: "After early success, South Africa buckles under coronavirus surge." So it's not unique to national disease control programs in South Africa. I think in many other low and middle income countries, the burden of coronavirus is really exerting a lot of pressure on your daily work. As I would call you, your team as really first responders. What innovations are you specifically seeing that have been beneficial for both COVID-19 response and TB control in South Africa? Those solutions that are working for both diseases. Can you share with us?
Yes, I'd like Corey to share one of the slides of. Can we move to the next one? Next one, please. So this was just to highlight the decrease in terms of patients' attendance. As you can see, we're really in trouble there. But let's move to the next slide. I think that's what really will help us. Like I indicated earlier on, we've identified a lot of challenges, starting with drug stock out, A lot of our staff members have been transferred to support COVID. So all these have led to what we see now as a result in terms of decreased case finding and all that. But the truth is, we've known that we will not be spared by this pandemic. We were told very clearly, repeatedly so by our local experts, that all initial efforts were just to shift the peak and then give us chance to prepare. And these are some of the things that we're doing to respond in the middle here. We're now able to work even more closely with our colleagues who buy the drugs. I've just noted that we have more meetings than ever before. We talk weekly with our provincial colleagues, the TB managers. They initially, there was lockdown, we're all in our corners. Then after a few weeks, we started meeting weekly. Now it's going to be bi-weekly. But definitely the cohesion is much better. Monitoring is happening much better between us. And innovative way of TB screening and COVID, using apps, all these are very, very important. I must say that one of the things, the benefits that we had, apart from introducing oral regimen ahead of all this, one of the things that we did was decentralization, whereby we reached more than 90% of our sub-districts having at least each a treatment initiation site for MDR-TB. All our, out of 262 sub-districts in South Africa, 233 or 240 have treatment sites. Now, what happens is that at our bigger admission sites, 33 of them in the whole of South Africa, we have 3,798 beds. Our bed occupancy rate from last year has been like 50%. So to us now, because of this strong decentralization, COVID is an opportunity now to get these other part of the DRTB sites populated. I'm hoping that we will see bed occupancy rates climb to maybe 70% for sometimes at our facilities, because when you run facilities at 40%, 50% occupancy, that's not efficient. So that's some of the things that we're doing. But there are also a lot of opportunities. Much as we have challenges, we need to leverage around the intersectoral relationships. We've never had so many meetings with the public-private sector. For many years, we struggled to get TB data from private sector. But when you look at the data that is produced now from South Africa, more or less half of it comes from private sector. The other half comes from the government sector. Initially, I think 80% came from private sector. So if we could continue working that way, even for TB, I'm sure that's going to be a big gain. If we continue with the sense of cohesion with private sector, with the research institutions, yes, we've been working with them for DRTB issues, but why can't we work for everything, Why can't we use technology? Infection control, we're now in a better position to get all our patients, including the TB ones, wear masks at facilities. It has been difficult even to get proper masks, even just respiratory, even just surgical masks for healthcare workers at general facilities. Now everyone in the community has. So I think this is our opportunities that are going to help us the willingness around, the mood of the people wanting to help. We've been having sessions of COVID training sessions with China, experts from China, and it's been very interesting. I don't remember all my years working as a physician. I don't remember having spoken to people from China, but recently we've been sharing experiences with Chinese, and on the call I've seen several African countries. I think there are a few opportunities that really could assist TB case finding, screening, case finding, and hopefully improvement in terms of infection control. But again, all this will not happen by chance. We have to work very, very hard. And I think the central piece that we're working on now with our provincial colleagues is to work on catch-up plans to bring people back. Our patients who have gone out of the system, we bringing them back. I think that's probably the central piece that will help us, transform, transform these opportunities into real, results, successes, and all that. So this is in a nutshell what I can say that we're trying to do in South Africa. Thank you.
No, thank you very much, Norbert. It's quite helpful to see what the TB control program is doing by way of even strengthening aspects of the health system, and particularly the intersectoral collaboration and the coordination with the provincial offices, and improving the efficiencies at hospital level, the capacity and bed occupancy. All those are positive. But Madhu, a month ago, you wrote an interesting piece in the British Medical Journal titled "Ensuring the Continuity of Tuberculosis Care During the COVID-19 Crisis," in which you outlined 10 strategies. Can you take us through some of those strategies, the one you consider as priority and more impactful?
Thank you. Corey, could we have my slides back? Okay, so I think by now, listening to our colleagues, it's very clear that COVID has a devastating impact. How bad will it be? I guess the mathematical models are one way to kind of think about them. There's at least now 4 mathematical models that I'm aware of on exactly what COVID could do to TB. Obviously, it's a very dynamic situation that's evolving in many countries, so it's hard to kind of pin them down. But this is one model by the Stop TB Partnership and Imperial College and other colleagues suggesting that in the next 5 years, we could see almost 1.5 million additional TB deaths and about 6 million new additional TB cases. Next slide. So here are, I think, some potential solutions that we and others have outlined. I think first, as Norbert mentioned, the critical thing is do not stop ongoing services. And this is obviously easier said than done when you're in the midst of a lockdown. And that's where we are learning that even though many TB programs intend to keep the service going, people simply cannot leave their homes. So just because a facility is open doesn't mean anyone is going to show up. And I think this is where some of the innovations that Lisa mentioned are critical. We just don't expect them to come. We get the treatment to them. I think that is where I would love to see more positive examples on, if you can order food and have it delivered on a motorbike to your home, there is no earthly reason why TB medicines cannot reach you. Secondly, to add to that point, how do we ensure supply of enough medicines? I really like the multi-month dispensing approach. I think multi-month dispensing should be the norm. But the trade-off here is if TB programs don't have sufficient medicines forecast, or if GDF does not have sufficient medicines, then dispensing 3 months at a time might deplete the NTP stocks quite badly. and that might push us all into a supply crisis. So I would love to see a nice analysis on how much medicines we have as a TB community for this year, what will we need for next year, and what will the need be if we all switch to 3 months, for example, for every TB patient, right? That kind of forecasting would be very valuable, I think. Recently, UNAIDS put out an entire report on their assessment of antiretroviral situation, and they have predicted stockouts of ARVs. So if ARVs are going to get stocked out, and HIV being such a high priority disease, then how can TB be spared, right? So we need to anticipate it. We need to advocate with countries like India to make sure that they resume TB drug production. This is critical both for Indian TB patients and for the rest of the world. And then do not stop testing for TB. Again, this is easier said than done because COVID testing itself is a bottleneck, and most countries are desperately looking for pipettes, reagents, machines, staff, whatever they can find to just get some COVID testing going. And so my concern is if TB completely falls off the radar there, I'm happy to hear from Lisa that there are countries that are trying to do both. Maybe run Gene Expert for TB during the night and COVID during the day. One way or the other, we have to somehow keep TB testing going. If TB testing drops, we're all in serious trouble. So that's no question about that. And then find a way to integrate TB and COVID testing. For example, we know now Gene Expert can do both, right? But if I have to now get one different sample for TB, one different sample for SARS-CoV, and I have to send it to one Gene Expert lab for TB, another Gene Expert lab for SARS-CoV, or if the biosafety levels are very different for the two technologies, then I think this is going to be really challenging. TB and COVID have similar symptoms, cough and fever. So can we find a way to run both tests on the same patient, on the same sample, in the same laboratory, and figure out whether they have COVID or TB? Can we do some operational research around this? We're trying to do that in Peru with a grant that we got from the Canadian government, but it'll be nice to see many others innovating in that space. South Africa is a brilliant setting to pull this off and show that it is safe and feasible to do the same sputum sample and run both COVID and TB tests on them. And I think we discussed the switch to all oral regimen extensively. This is a done deal. We absolutely cannot go back to injectables. We cannot go back to DOT. We have to find a way to make this work. And this is maybe one silver lining in this entire pandemic. And as I said, let's be aware of disruption of not just drug supplies. Let's also be worried about potential stockouts of Gene Expert and line probe assays and midget, because every single diagnostic company is COVIDized right now. They're all scrambling to meet the demand. They're all running flat out on COVID. And I think we need to worry about what it can mean for TB medicines. And we should all advocate to resume production or not stopping production of critical TB supplies, including first-line drugs, bedaquiline, Gene Expert, so that we are not in a deep crisis in 2021. Thank you.
Thank you, Madhu, for that. We just received a question from Gulam. Maybe you may want to take that. Gulam says, considering new circumstances owing to COVID-19, what are the predictions of TB? Shall the estimates published earlier are still valid, or might they change? So in other words, some of these predictions that we are basing, recommendations on may be outdated as the epidemic matures. What is your take on that? And before you answer, I would like to ask the audience to post their question in the chat function, so that we will take them in the end of toward the end of the conversation. Madhu, over back to you.
I think the depressing reality is situation is getting much worse in the highest TB burden countries now compared to where we were in March or April. For example, South Africa had a very low incidence in March and April. So was India. So were many of the highest TB burden countries. None of that holds now. Just take a look at Brazil alone right now, right? Brazil is absolutely going through the ceiling. So is India, so is Russia, and those are 3 high burden countries. South Africa is starting to escalate. Indonesia is escalating. Philippines is escalating. None of these countries are even close to reaching their peak. Pakistan is escalating as we speak. So I'm super nervous that the damage will be way worse than what the models predict. And secondly, we were all naive. When I say we, I mean the whole world was naive in thinking that one lockdown will somehow flatten the curve. And as Lisa mentioned, it just takes us a few weeks of relaxing the lockdown, and then we see a nice, huge spike. And that's happening in every single place. European countries that had flattened the curve are now seeing peaks, right? Australia is seeing another peak and gone skyward again, right? So we simply cannot relax against this virus, which means these repeated lockdowns, if they continue throughout the fall until next year, then I don't even know how devastating this can be for TB, because the models only modeled up to, say, 3 months of lockdown, right? We're well past that stage right now, right? We're now looking at multiple lockdowns, cities getting locked down, opening, again going back to lockdown. So I think the models have to be revised, and I think everybody understand that this is not an epidemic that you can easily model and consider it a done deal, right? The dynamism is immense. Latin America now worries the hell out of me, right? Latin America as a whole is now absolutely the continent where the new epicenter of the pandemic is now Latin America. And we know there are high TB burden Latin America countries as well. So the depressing quick answer is no. I think the estimates will need to be revised upwards.
No, absolutely. I want particularly to touch on the private sector because both Madhu and Norbert, you alluded to it. And I don't know, Lisa, if you have a perspective on that. Private sector involvement, engagement has been in every document that we have written every year as a TB community. But it's such a big elephant, right? I mean, what does it mean to engage the private sector in the context of COVID-19? I mean, we could talk about it from a service provision perspective. Norbert alluded to the availability of data that now sharing, and the private university, the university and academia also engaging at evidence generating. Lisa, what has been your experience working with the private sector in Asia Pacific?
Yeah, I mean, I think we've been struggling pre-COVID to figure out how to engage the private sector, and the private sector is varied. What I know from across Asia is you've got your informal private sector, and then you've got some highly sophisticated formal hospitals. But TB engagement has been challenging. We've got a program just focusing on that in Indonesia, working at district level approaches and national approaches as well. We've got work going on in Philippines as part of a larger project there. But that's all even pre-COVID. So yeah, how they play into it now, it's difficult. We're doing some of the drug delivery programs in Indonesia are based out of the private sector hospitals, as well as drug-resistant TB patients who are coming from both private and public. But I think it's kind of a black box. And as Madhu said, people depend on the private sector, and their response to COVID will be different. They have a different business model. The funds are pouring into the public sector for COVID. So some of these hospitals may be going under, and yet that's the facility that's closest to people's homes in many places. It's the pharmacy on the corner, or the informal provider right there in their small community. So I don't have the answer to how to fix the problem, but I see that it is going to be a major issue that we have to tackle.
Will it be a question of incentivizing them differently and maybe coordinating them differently? No, but what is happening in South Africa? What would you attribute the positive engagement during COVID-19 with the private sector in South Africa from an incentivization perspective?
Yeah, I think the TB community, TB program tried to work with them. It didn't work in the past. But when COVID came around, it is now the minister, it is now the state president that goes to the private sector and tells them that, look, guys, this is a problem we now have as a nation. Can you help with 1, 2, 3? And of course, it's not like, you know, they just do it for free, because private sector is there for profit. You know, but providing the test to them, you know, has been very helpful. But I think it is, for me, what is the most important thing here is the political commitment. The state president asked for it, the Minister of Health asked for it. It is working, and I think you know, if they go back to the same people and say, guys, now please, let's do the same way for tuberculosis, I think it is also possible. I mean, we got bedaquiline in the past, we got so many things, gene expert and all that. Our minister understood the need for all those things. He was pushing for them. But maybe because he had a lot of work to do, he never really looked at the private sector as a priority. But I think moving forward, we need to bring politicians. It has to start with political commitment. I think it can be done. Yeah.
So Madhu, from your PPM working group perspective, you're actually seeing that sector shrinking, which is worrisome. It wasn't really big engagement. Now it is even getting smaller. How do we stop that downward trend?
I mean, I don't know, I might be overreacting, but I think the pandemic has been catastrophic for the private health sector. They were very vulnerable, and many of them will probably not recover in terms of their ability. Imagine losing 3-4 months of revenue, and to having to fire their staff, to not being able to pay the rent, right? Many hospitals are in rented facilities, they can't even pay the rent. So there's already some discussions in some countries on the private health sector receiving a bailout, but then the public sector itself is struggling and the economy is tanking. So how do you now justify bailout of the private health sector? So for sure, this sector is changing dramatically. Many of them might find a way to live by just switching to online consultations, or finding a way to kind of bring back some revenue into the system. And I'm not sure how good or successful those approaches are yet. And we are hoping to track some of them through our 3BPPM group. I think I'm 100% aligned with what Lisa said. Even as of last year, TBPPM wasn't quite great, right? We were just about starting to find ways to work with them. We had some success stories in some countries. So to bring it back to end of last year would be a Herculean effort with this pandemic. Now, what I will say is that the impact on private sector is not just for TB. Let's be clear about that, right? It's hitting them in every way, whether it's cardiac surgery or whether it's TB, it's all the same, right? Now comes a question. Are countries that already were working reasonably well with the private sector, they had the regulations in place, they had strategic purchasing agreements in place, they had contracting in place, have they done much better in this crisis than those that had just allowed the private sector to do whatever they wanted? And now suddenly in a crisis, we're coming down very hard on them saying, why are you not doing this? We're going to cap your price. You're going to do this. You're going to do that. I think we can see already a diversion of those countries. Countries have found a way to immediately work with the private sector for a surge capacity, for additional hospitals. They've taken over private facilities. They've contracted private facilities. Those countries, I think, have done much better. Countries that rarely regulated the private sector, like India, are in dire straits right now, because in a crisis, you can't suddenly wake up and regulate and work and have contracting systems ready with the private sector. You needed to have that in place. And India, interestingly, you find state by state difference in how each state is working with the private health sector. Some states are so progressive and good, they've figured it out. Other states are really in desperate states. And so it's a completely disorganized way of working with the private sector. So about a week ago, I did a webinar with the health ministers of Kerala state in India and the health minister of Malaysia. And the Malaysian health minister, he said, we've used a whole of government approach to this pandemic, which means all the arms of the government, including the private sector, was called upon to serve in this crisis. And it has worked beautifully for us. I think that is the message, that the country response to COVID and TB needs to be the whole of government, and private sector is a critical part of it. We cannot not tap or harness the private sector in a crisis, because public sector capacity is low in many countries. So how do you then deal with this COVID surge and TB and 50 other things if you don't leverage the private sector at your disposal, right? So WHO is putting out a roadmap and a comprehensive strategy document on how private sector can be efficiently engaged in the COVID response, but it clearly applies to TB as well. I think this may well be the landmark moment in how the world deals with the private health sector, because if they have not showing up in this crisis, they're going to have a huge problem in justifying their existence. At the same time, they're also very vulnerable if sufficient effort is not gone into harnessing them and tapping them. So I think that is the lesson we are all learning. Otto is dropped off.
Yeah, thank you so much, Madhu. I think, and I want to thank, my name is Doris Machari. I think Otto is having some few challenges in connection, you know, with, with our COVID situation. We also have internet connectivity problems, but, you know, we've only got about 4 minutes, and just want to, you know, ask our panelists maybe for last thoughts as we wrap up. We still certainly have a few more questions, and I'll just, you know, request those that we've not been able to get to, that we will certainly come to those and try and answer in subsequent, I think after this panel. Maybe let me start with, because we've heard from Madhu, if I can just sort of do a round robin, maybe from Lisa, if there's anything else, just last thoughts from you, and then we can begin wrapping up, then Ndjeka, and then we end it.
Thanks. Yeah, so I think just as last thoughts, I'm optimistic that we're learning some lessons and gaining ways to actually improve our TB services. And I think we can hopefully move those forward with us. We need to protect what's happening with TB eradication efforts while we're at the same time trying to fight against COVID, and work from the global level, national, regional, all the way down to the community to try to strengthen our health systems, to work for a stronger health system that's going to respond not just to COVID, but to keep fighting TB even after that with whatever comes next. And I think we take what's been forced on us by this epidemic and use it to improve how we find, prevent, and treat TB, to work towards TB elimination. And I just want to thank you all for letting me be involved in this webinar. Thanks.
Yeah, thank you so much, Lisa. And Dr. Ndjeka, I almost feel like you're next door to me, but last thoughts, please.
Yes, so my last thoughts really is, I have two. In terms of medicine distribution, for example, in our own setting, CCMD has been there for years, used for HIV patients. We're just starting for TB. It should continue. You know, we have some of the tools at our disposal. We need to make better use of them. But my last thought is the whole question of national health insurance. Now that the private sector is in trouble, is this not the time to fast-track national health insurance implementation around the world so that we could achieve universal health care for everybody? I mean, it pains some of us to see that there's medicines for rich people, medicine for poor people, and we don't even know where we belong. It's a big problem. I hope now is the time to fast-track NHI. Thank you.
Thank you so much, Dr. Ndjeka. And Madhu, yes, of course.
Yes, just one last appeal. And I make this appeal at the end of every TV webinar that I'm on. I recently wrote a paper in Nature Medicine called COVIDization of research, right? I'm worried that everybody and everything is COVIDized. I understand why that's happening, All researchers are working on COVID, all funders are funding COVID, all journalists and journals are only interested in COVID. I get it. At the same time, if we forget diseases like TB, I think we are looking at catastrophic consequences. So at least some of us, I argue in that paper, should be designated drivers. We have to stay laser focused on TB. Even if some of us in the TB field must respond to COVID, at least a few of us have to stay the path, because the path just got much harder. And if we all diverted our talents away from TB, it would be a disaster for all of us. So please stay focused on TB if you're passionate about TB. Thank you.
Yeah, thank you so much, all of you. I just want to thank the panelists for being such great champions and very passionate. I mean, you've certainly really given us such great information. And I think we're much richer now in terms of how, the gains in TB and what we need to do and what we need to also support in our various programs. So thank you very much. It's really been an amazing, I think even various participants are saying an amazing webinar. Thank you so much, Dr. Stevens, Dr. Ndjeka, and also Dr. Madhu. Thank you for your time and your thoughts and your advice, suggestions. We really want to thank you. And from our panelists, thank you, our participants. Thank you very much. And please do have a good day, stay safe, and keep tuned to the TB agenda as it evolves in this COVID times. Thank you so much, everyone. Have a good one.
Thanks,
Thank you.
Bye.
Bye.